and thank you for bearing with us towards the end of this morning session today. So I'm Leana Wen, and I have no slides, although I do encourage you to tweet to me, and I'm going to write down my Twitter handle. This is the only technological thing that I'm going to ask of you, Dr. Leana Wen. And as was mentioned, I'm an emergency physician, and so quite relevant to our topic just now. And Catherine also gave the perfect segue, actually, into the topic that I'm going to be speaking to you about. I was initially saying to people this morning that I might be the least popular speaker of this entire conference because I'll be talking about returning to the basics of what happens when we go back to the story and go back to the most low-tech solution in this high-tech world. And so speaking of stories, I want to start today with two stories, both stories of patients. The first is of a gentleman named Jerry, who is in his early 40s and is a car mechanic based in Boston. He goes to the doctor because of some chest pain, and he goes to the ER where we see chest pain quite a lot. And so he says, you know, I have chest pain, and immediately gets hooked up to machines, gets an EKG done, gets a chest x-ray, gets blood work done. But if the doctor had actually asked him what was going on, he would have said that his chest pain started after he was moving boxes. And in fact, it wasn't just chest pain. It was also pain in his back, in his arms, in his legs. He was sore all over. And yet, he had found out that if you have any kind of pain between your belly and your neck, right, you hear this in the news, that you have to worry about this being a heart problem. And so that's why he was in the ER. Well, so he gets all these tests done. The doctor says to him, we need to make sure you're okay, so you have to stay the night. And the next morning, Jerry gets more tests done. He runs out on a treadmill. He does some more blood work. He does some more EKGs. And at the end of all of that, the doctor says to him, congratulations, you don't have a pneumonia, you don't have a collapsed lung, you don't have broken ribs, you don't have a heart attack, you have chest pain. And so Jerry says, but I don't understand. I came to you saying that I have chest pain. Why am I leaving with no more information than what I came in with? So, of course, he still has no idea what's going on. And so he goes back to see the doctor in a few days. And the doctor then says to him, have you had more of this pain? He says, yes. So this time he gets referred to see a cardiologist who does a catheterization. He goes to see a GI doctor who does an endoscopy. And again, the good news, his heart vessels look fine, and his esophagus, stomach all look beautiful, but he still doesn't know what's going on. And in the process of getting all these tests done, he suffered a pneumonia, a wound infection, and a blood clot in his legs. And so is Jerry a victim of overtreatment or a beneficiary of really thorough medical care? I want to go to story number 2, which may allude to some of the issues we were just talking about in the last speaker's session too. This is of a woman named Sandy who is also in her early 40s, mother of 2, school teacher in Los Angeles. She goes to the doctor because of several months now of not feeling very well, feeling run down, having a cough, feeling tired, being short of breath, just very vague symptoms. The doctor takes one look at her. She's Chinese American, immigrant, and says, oh, you're fine. I'm sure, you know, there's nothing really going on. Maybe this is a virus. So she says, okay, I believe my doctor. I think there's something going on with me, but I can't really speak up, right? And so she goes home. A few months later, her symptoms are still persisting. She goes back to see the doctor. The doctor then does some tests. We don't know exactly what they are, but we think there's some blood tests looking for anemia, maybe looking for thyroid. And the doctor says to her, oh, well, these are all normal. You're fine. It's all in your head, right, is the implication. Because he says to her, if you're still worried about this, why don't we try some Prozac? Maybe you're depressed. So she tries the Prozac because, again, she doesn't want to tell her doctor you're wrong, right? Tries the Prozac. A few more weeks go by. She feels even worse. Goes to see a second doctor who reads the records of the first one and says, oh, you're depressed. Maybe now you're anxious. Try some Valium. Basically, it's not until about a year later that she's finally diagnosed with breast cancer that by that point was widely metastatic, that has spread to her lungs, to her bones, and to her brain. So I tell these stories because we know all the problems with medical care. We talk about them all the time, the cost of care. We talk about cost all the time, that it's, you know, no matter where on the political spectrum you are, nobody says that healthcare is perfect, right? And we all know that of the $2.7 trillion we spend on health, that 30% is waste. That's a lot of money. That's $750 billion of unnecessary tests and unnecessary treatments. And now there's another side too. We also talk about diagnostic error, right? We talk about how medical error kills 100,000 people, maybe even more, every year. And we also know that the #1 cause of medical error is error in diagnosis. And so how do we reconcile these? I mean, the case of Jerry, he got too many tests. But some people will say, well, in the case of Sandy, the school teacher, maybe she had too few tests. I mean, whenever I present this case to medical students, they'll say to me, oh, well, here's the problem. She should have gotten more tests done. Or if only we had a better test. If only we had a test looking for breast cancer in the blood, she should have gotten that test. Well, I would say maybe that's not the problem. Maybe the problem is that in both of these cases, the doctor didn't listen. The doctor didn't pay attention to the story of why the patient came in the first place. In the case of Sandy, even if she'd gotten every single test that the doctor did on Jerry with chest pain, the answer would not have been received, right? The right answer would not have come about. And the implication of all these tests that she did have done was what? She was crazy. If these tests were negative, she's crazy. So that's not the answer. That's why I argue that we have to go back to the basics of the story. Now, we know that the story is powerful in other aspects of our lives, right? And journalists use the story to get your attention. We also know that it's used in advocacy, that the story is what gets our attention from the get-go. We talk about stories because ultimately we're helpless with numbers. We can talk about 21 million starving Africans, but people don't give money to 21 million starving Africans. We give money to the one starving child whose picture we see, whose story we hear. And I find it fascinating, too, that in this conference, where we have all of our laptops out and we have Facebook and Twitter and everything out, that when we talk about story, that's when someone looks up. And even in trying to talk about why we need all these devices and high-tech devices, that we all start with a story. And yet, why is the story being lost? Well, I'm sure there are many reasons for this, right? There's time. We were talking about how doctors have less and less time to listen, and that's so true. We know from studies, too, that the doctor will interrupt you in less than 10 seconds after you start speaking. Now, how much of your story can you get across in 10 seconds? And medical practice is to blame for this. Medical training is to blame. We were talking about medical students and how they learn earlier, right? And so medical training, we learn all about science. And I'll share a quick anecdote, too. I was giving a talk a few months ago, and it was a talk about some cases of misdiagnosis, and somebody raised their hands. One of the students raised their hand and said, excuse me, is this a talk about empathy? And I thought, well, kind of. I guess everything has to do with empathy and compassion in some way. And so he said, well, I'm sorry, because we did hear a talk about empathy a week ago, and I have to go study for my biochemistry exam. I don't think he was trying to be rude, but there's so much information that we're cramming into medical training, and where we look at the history as another checkbox. We learned the history today. We learned the CT scan, right? This is one more thing that we have to learn. But you know what? Patients, all of us, the public, we are all complicit in this too, because we all buy into this idea that new is better, that technology is good, and that we should use that not to augment necessarily, but to replace. Right? That's why when hospitals advertise their newest machine or why you should go to their hospital, they say, we have 10 state-of-the-art MRIs, that we have robotic surgeries. They don't say we have the best doctors here who listen to you. When you look at ads on TV for drugs, they don't say, talk to your doctor about this drug and have this whole discussion. It's, here's why this drug is amazing. Ask your doctor for this drug, right? Because we buy into this too. So I want for all of us to turn back the clock so that we don't treat patients as body parts, and so that we focus on the art and the science of medicine, and so that we return to the healing in addition to treating. So what I'd like to do now is to share 3 things that I want patients to keep in mind, and 3 things for doctors and providers to keep in mind too. So the first, for 3 skills, really, for patients to tell their story. The first skill is I want you to think in terms of your story and not in terms of your symptoms. Now, people will look at me, I'm sure at this point, and say, why? Patients, we're supposed to think about our symptoms. We're supposed to talk about our pain and our, pain on a scale of 1 to 10 and all these things. But let me give you this example. So let's say that you go to the doctor and you say, I have chest pain. What's the doctor going to do? He's going to say, well, when did it start? What did it feel like? What are the associated symptoms? That's what we learn in medical school, right? But let me give you a thought experiment. Let's say that you haven't seen an old friend for a while. Maybe you met them at another conference 2 years ago, 3 years ago. You run into them here. What do you say to them? You say, how have you been? What have you been up to? How are you, right? You don't say, are you employed? Did you get fired from your last job? Are you married? Are you divorced? You can ask them all these questions. You'll get some kind of answers until they look at you strangely. But I would argue that you wouldn't get nearly the nuance and depth of answers that you would if you just asked them for their story to begin with. And yet we go to the doctor and we say, I have chest pain, and wait for the doctor to ask you questions. What about instead say, I was walking my normal 3 miles every day when I experienced this pressure in my chest? That takes less than 10 seconds, and that really gets the doctor's attention. Number 2, provide context. Don't say things like, I have epigastric pain, and use medical lingo and say, I have pain 8 out of 10. What if instead of saying, I have a headache that's 10 out of 10, you said, my headache has been so bad that I couldn't go to work for the last 3 days? Isn't that a lot more telling? Number 3, start with a high-impact statement. Knowing that you have limited time to get your point across, start with something that really gets the doctor's attention. So instead of saying, I've been more short of breath, say, my short of breath has gotten so bad that I can't walk from the bed to the bathroom, right? That's something that really gets the doctor's attention. Now, of course, I'm not saying that doctors are let off the hook and providers are let off the hook. I mean, we all have to be better. And so here are 3 skills that I want doctors to take away in storytelling as well. The first is to not focus on the chief complaint, to look at the broader picture and to really be open. Because otherwise, looking at the chief complaint is like writing a book based on just the title of the book alone. Number 2 is to listen and really listen. One of the exercises I do with my medical students is to challenge them in this no questions asked. I ask first-year medical students to try getting the history without asking any questions at all. And they'll say, well, I haven't learned how to take the history. I don't know how to do that. But you know what? They actually take an incredibly good history. That's a lot better than the history they end up doing when they're third-year medical students, a lot better than when they're interns and residents. And I think that says a lot about our medical training, right? That we're failing our trainees, and therefore we're failing our future patients. That we're training them not to listen. We're training them to ask open or closed-ended questions rather than open-ended questions. And we're actually failing generations of people afterwards. So we really listen. And the third is to not assume. We make assumptions of our patients all the time about are they sick or not sick. But you know, a few months ago I was giving a talk and a woman at the back of the audience raised her hand and said, I want to ask you, what do you see when you see me? I had no idea how to answer this, right? I mean, I don't know what to say when somebody says it. She was an older woman in her 70s. I had no idea what to say. She looked at me and she said, I'll tell you what you see when you see me. You see an old woman. You see someone that if you let me talk, that I'll just wax on and I'll never stop talking. And I know that's what you see because that's what my doctor sees when he sees me. And that's why he never listens. And yet this woman, she was a founding dean of our nursing school. And she, of all people, she wanted to be a partner in her care. So for all of these things, I encourage you to practice these skills because anything requires practice, right? And to spread the word, to write about it, to blog about it, to tweet about it, as you all are doing. And if you wonder if things can't make a difference, right? We do know from studies that what you do with your doctor will make a big difference in your care. We know that 80% of the history, or 80% rather, of diagnoses can be made just based on your history alone. Time and time again, studies in the 70s, the 80s, the 90s, and now show that the history is the most effective test that's out there. More effective than any single test or combination of tests out there that's available. So really focus on your history. And studies also show that what you do with your doctor will make a difference with other future patients that that doctor sees as well. If you want more convincing, I want to go back to our 2 stories in the first place and just mention about Sandy, the school teacher. You know who Sandy was? She was my mother. I was a medical student when she began telling me that she was having all these symptoms that she couldn't explain. And I would go with her to the doctor. She was living in LA, and I went to medical school in St. Louis. And I would go with her to her doctor. And she would say to me, don't speak up. Don't tell the doctor about what's going on. And the reason was she was so afraid. She was afraid of being perceived as a difficult patient. You know, she was an immigrant, not used to going to the doctor at all, right, because she never got sick. But she was so afraid of the repercussions if she did speak up. You know, she passed away 3 years ago. And don't think that I don't wonder every single day, what if I did speak up? What if I did insist on telling her story? What if I did say, it's so important that you convey your symptoms, that you tell the doctor exactly how you're feeling? So if there's any doubt from any of you that one person and one story can make a difference, then please let this be my lesson. You must tell your story. Thank you.